This podcast is sponsored by Well Medical. Well Medical specialises in life-saving defibrillators and emergency medical equipment. Trusted by healthcare professionals and first responders across the UK, they're committed to making high-quality, reliable medical tools more accessible. In a world where every second counts, Well Medical provide cutting-edge defibrillators designed to be easy to use even for non-professionals. Their products help improve survival rates in cardiac emergencies, making them an essential tool in schools, offices, gyms and public spaces. Their most popular model, the iPad SP1, offers voice prompts and simple visual aid, ensuring anyone can confidently administer help. Beyond defibrillators, Well Medical offer a range of first aid supplies, making them a one-stop shop for emergency preparedness. They also provide training and support, ensuring individuals and organisations know how to use the equipment when it matters the most. Well Medical doesn't just sell products, they're passionate about saving lives, so their dedicated customer services and comprehensive support ensures peace of mind for everyone who invests in their life-saving technology. So visit Well Medical today to learn how you can make your space safer for everyone. You can also visit the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the Pre-Hospital Care podcast with me, Owen Walker. In this episode, we're speaking on 12-lead ECG algorithms with Professor Peter Macfarlane. So in the episode, we really wanted just to delve into the history and indeed the development of ECG algorithms with a true pioneer in the field. So we're going to explore the early days of ECG interpretation. We're also going to explore the challenges in developing automated algorithms. And then we're also going to unpack the evolution of this vital technology. So our guest today is going to share some of his insights from decades of experience, including his work in establishing an ECG Core Laboratory for clinical trials and indeed epidemiological studies. The Glasgow ECG algorithm is the prevailing ECG algorithm used globally, and indeed it's helped many thousands of clinicians worldwide in their interpretations of 12-lead ECGs. To do this, I have Professor Peter Macfarlane with me. Peter is an Emeritus Professor and Honorary Senior Research Fellow at the University of Glasgow. His team's work include the University of Glasgow's ECG Interpretation Program, which is utilised globally. Peter's research has addressed ECG variations due to age, gender and ethnicity, shaping international guidelines for diagnosing acute myocardial infarction. So he's established an ECG Core Laboratory for national and indeed international clinical trials. And he's also developed epidemiological studies, which really have formulated a baseline of ECG interpretation. So Peter is a fellow of several prestigious societies, including the Royal Society of Edinburgh, indeed also receiving a CB, so a Commander of the British Empire, in January 2014 for his services to healthcare. Welcome, Peter, to the podcast.
Thank you.
I just wondered if we could start, Peter, by just really digging into the early days of really formulating ECG interpretation. Maybe could you speak to just what prompted the need for automated algorithms and indeed where the idea came from?
Well, I became involved when the cardiologists in the Royal Infirmary in the mid-1960s thought it would be a good idea to automate ECG interpretation. So I really started with an empty room, paper and pencil. But prior to that, some cardiologists in Washington had also the idea of interpreting ECGs by automated methods. Hubert Puttberger used the XYZ lead system and Cesar Cáceres used the conventional 12-lead system. So that had excited the cardiologists in Glasgow, and I applied for the post of developing such a system there. So that formed part of the PhD, my PhD course. So at that time, ECGs were reported by sitting down with a secretary, dictating answers. The secretary had 4 carbon copies or whatever, and the reviewer would sign off the ECG. It was put in an envelope, and that was the way it was done. So it was a bit of a chore to provide a routine ECG reporting service, and I think that also stimulated the cardiologists of the day into looking into automation. So the challenge really then began with a paper and pencil as to how we were going to do this. So that necessitated a lot of reading, of course, into electrocardiology, into computer techniques, into the wider aspects of medicine and the role that the ECG had to play in diagnosis. Finally, we had a breakthrough with a grant from the British Heart Foundation to enable us to buy a small digital computer. In addition, we obtained a multi-channel analog ECG recorder, and so we were able to record the 12-lead ECG as 4 groups of 3 leads simultaneously at that time. So there were 4 10-second segments of 3-lead ECG, of 3 leads that we recorded at that time. And with the small laboratory computer, we were able to have it act as an analog to digital converter. In other words, the electrical signal of the ECG became a numerical or digital record on the small PDP-8 computer, which actually was sort of the world's first laboratory computer. Unfortunately for us, the company based in Massachusetts set up a small sales unit in Reading, and that's where we made our first purchase. In passing, the company had been in Reading 60 years, and they are now holding or organizing a big exhibition of 60 years of digital equipment or DEC in Reading. Now, the software was developed initially in Algo on a large university computer. There was a bit of a mismatch in that the digital data from the laboratory computer was recorded onto what was known as DEC tape, a rather non-standard tape format. And this was not compatible with the KDF9 name of the computer in Glasgow University. At the time, the 2 tapes were not compatible. Fortunately, when I was on a training course with DEC in Reading, I met someone who was working in Bristol on building the Concorde, the high-speed aircraft. They had a facility that linked the DEC machine to the KDF9 machine. So in the early days, we sent our data down to Bristol, and there it was transferred from the one tape to the other tape. I often had plane journeys down to Bristol to collect the tape rather than lose it in transit at that time. So these were the early days. So then we were able to record the ECGs in hospital, take the digital data to the university and analyze them using an Algo program. At the same time, of course, we had to accumulate ECGs from apparently healthy individuals. We had over 1,000 initially in 1970. And we had to do this using the orthogonal lead system. That's 3 leads, which were very approximately equal to leads 1, AVF, and V2. In other words, the direction or the axes of these leads were kind of mutually perpendicular to each other. And the reason for that was it took 1 minute on the small digital PDP-8 computer to analyze these 3 leads. So gradually, we transformed the Algol or high-level language, algorithmic language, into the low-level machine language required by the digital equipment machine. And eventually, we were able then to do all of the recording and interpretation on the small computer in the Royal Infirmary in Glasgow. Now, the small computer had expanded a little bit to include large disks. And when I say large disks, I mean physically large disks, about 15 inches in diameter, and they stored the magnificent amount of 830K of data. And at the other end of the equipment, we had a huge line printer to print out the results. And we also had an analog printer for the ECGs. But by the early 1970s, we then had automated ECG interpretation using 3 leads. And that then expanded with the addition of rhythm analysis and ultimately with serial comparison as well. This led to the establishment of a routine service for ECG analysis and interpretation within the Royal Infirmary. Now, the problem was the physicians, let alone the cardiologists, were not familiar with the 3 leads, orthogonal leads that I'm talking about. The real name was the XYZ leads, and I've said they're similar to one AVF and V2, but really the demand was for the 12-lead ECG. So gradually we transitioned to recording 12-lead ECGs, and that meant that one of our medical physicists designed and built a small electrocardiograph that could record all 12 leads simultaneously. And that was a tremendous advance and very significant achievement by Dr. Mark Watts at that time. And this led us on to new work. All 12 leads recorded simultaneously, therefore wave recognition was a little bit easier. And we moved to a larger computer, a PDP-11 computer. So that helped us up the ladder, shall we say, in setting up an enhanced ECG interpretation system within the Royal Infirmary. And then one thing led to another through the years as the program evolved.
And Peter, like you said, it's been an iterative process, and you've just described some of those iterations actually, and actually you've really spoken about the development process over 50 years ago, really, and starting to, like you said, gain a baseline of healthy ECGs as a comparator, progress and migrate towards the 12 lead, what we know now to be the 12 lead ECG, and the 12 lead ECG has become the standard of care almost around the world, really, for part of the fundamental diagnosis. Could you maybe speak to, just because as like you said, you're starting to iterate and build on the technology, and it's starting to become more and more sort of fine-tuned. So the accuracy and indeed the validity of the interpretation is becoming sharper. Could you maybe speak to what methods you use to validate the accuracy of interpretative algorithms?
Yeah, well, arrhythmias, if I start with rhythm analysis, it's a case, as you will understand, of a kind of visual classification of the ECG. And that's perhaps the most straightforward aspect of classifying or constructing a database, even if it's a local database, with which you can assess the performance. It gets a bit more tricky when you're trying to establish criteria for left ventricular hypertrophy, LVH. Of course, Sokoloff and Lang published criteria in the early days based on a limited number of patients. I actually spent a year off and on in the mortuary with Professor of Medicine from Canada who wanted a year out to relax after having been dean for many years. So we weighed hearts, etc., and looked into the sensitivity and specificity, etc., of various criteria at that time. So that was one other approach. Within our own area, then there was obviously limited numbers of ECGs that could be used for assessing the accuracy. But we established, or there was established, a project in Europe called Common Standards for Electrocardiography. And that lasted from 1976 through to 1992. The leader of that project was Jos Willems from Leuven in Belgium. And as part of that, then a database of ECGs with clinical classification of the patients, that was established. And that helped many groups, including some that were commercially available, involved at that time. That helped many groups to standardize on how to measure the components of the ECG. In other words, what's the smallest wave we're going to accept? What is the definition of the baseline, and so on. And also sensitivity and specificity of the major categories could be assessed using the database that was built up by the CSE study. So that was one of the main ways that everybody enhanced their diagnostic criteria. So quite a large number of groups were involved in that study.
And Peter, could you, at this time, could you maybe then speak to the adoption of the algorithm into what we would say, I guess, heterogeneous, different physiological monitors? So just the adoption of the algorithm into hospital and or pre-hospital monitors, and indeed maybe how it was being received by clinicians in hospital and maybe indeed out of hospital.
Well, with respect to our own algorithm, the word to use would be serendipity, chance. We had developed the program with support of the Scottish Home and Health Department, as it was. This was a new 12-lead program, quite distinct from the original XYZ lead program. And we were expanding the hospital. Royal Infirmary was expanding at that time with new cardiac catheterization labs. That technique was also evolving at that time. And a salesman from Siemens Elima in Stockholm was visiting the hospital to try and sell cath lab facilities. And when he was there, he said, kind of look around and see what you're doing. And we showed him our interpretation. And he said, we have to have that. And that led to an agreement between the University of Glasgow and Scottish Government to allow Siemens Elima to use the Glasgow program. And so really through the sales network of Siemens, the Glasgow program was then able to advance into different centres in Europe. And Siemens then bought a small company called Burdick in North America. And they then put the Glasgow program into the Burdick machines. And that gave the program a very significant exposure in North America, principally, to be objective, in primary care. That was the field that Burdick sold most. And I believe that it became the most used program in primary care in North America through the 90s and beyond when it got going. And then, of course, one gathers feedback from here and there if some part of the software didn't seem to be what it could be, and enhancements were made. And we were just, I guess, lucky that some people quite like to use the software. So we have no control how the program is distributed. We just work at it, and if somebody likes to make use of it, that's very encouraging from our point of view. But I and colleagues are not out on the streets selling software.
No, indeed.
I don't know how to put it any other way.
Yeah, well, no, indeed. Well, Peter, to be honest, when I first started my postdoc career in 2001, it was very much embedded within the LifePack 12 and then LifePack 15 from Physio Control at the time, who owns the company prior to it being the acquisition from Stryker. But the algorithm was embedded within the Physio Control machines, and then, like you said, there's a real adoption ubiquitously across different companies, really. And let's just talk about, there is comparators. DXL is the Philips algorithm. There is the Levain algorithm as well. But the Glasgow algorithm, to my mind, has been, I think, pretty much one of the most ubiquitously adopted algorithms because of the sensitivity and specificity, because you've got such a large database of comparators, because there's been iterative improvement over time, and because I think you pretty much entry into service, it was one of the first algorithms of its kind, really, to flag an acute MI and or other types of pathology as well. So not just acute MI, but other types of pathology. Could you speak to that?
Yeah, well, certainly it is fair to mention Physio Control, because we did a lot of work with the company in the detection of myocardial infarction and acute myocardial infarction. I mean, the term STEMI was only introduced in the early 2000s. Up until that time, well, it was acute myocardial infarction. And one of the things I did try to bring to the attention of the cardiology community was that criteria for acute MI, first published by, let's say, American Heart Association and other such groups, had grouped V1, V2, and V3 together as having the same criteria. And I didn't think that was right. And I went back and looked at our normal limits and then produced a paper that showed that V1 was quite different from V2 in terms of normal limits of the ST junction, the J point. V2 was similar to V3, but crossing the sternum made a big difference in the normal limits of V1 and V2. Not only that, they were different between male and female. Normal limits were higher in males than in females. And I put that paper out, I think, 2001, and then worked with physio on age and sex-based criteria for the limits of the ST junction. We also showed that with age, the upper limit of normal of ST junction declined, both in males and in females. We then produced some papers showing that age and sex-based criteria for acute MI were definitely better than not having age and sex-based criteria. And that finally worked its way into the universal definition of myocardial infarction. And if I'm honest, it was a little bit disappointing that the work that we had done in Glasgow was not really acknowledged in that paper. But you will find then that by around 2012, we'd done enough and showed enough people that separating V1 from V2 was critical. And the fourth, or the current definition, universal definition of myocardial infarction, still separates V1 out, V2. In fact, they separate out V2 and V3, and then keep V1 and all the limb leads together in terms of thresholds. So age and sex based, but also separate V2 and V3 out from the other leads. So yeah, that was, I say, a little disappointing that we didn't really get any acknowledgement. And I think even if you look at the fourth universal definition, there's still not much in the way of acknowledgement to that work.
No, Peter, absolutely. And just looking at, so fundamentally, this is all about impact on patient care. And I think very much in the early 1970s, late 1960s, that was probably front of mind for you actually about how we impact patient care by coming to common understandings from an interpretation so that you can actually let clinicians get on with their jobs. They can understand the patient in front of them. They can start to understand the the ECG algorithm, or indeed, sorry, the ECG interpretation together with the clinical findings. And I've heard you speak about it before, fundamentally looking at the patient, matching it up with the ECG. It's one of the benchmark things, really. And, it's one of the things you always went. I remember you saying before, whenever you get an ECG across your desk, it's like, right, well, how was the patient presenting? Because this is a snapshot in time, but you've got to piece it together with the other information on the scene and from the scene. Could you maybe speak to that, because that seems to be almost an enduring characteristic across time?
Yeah, well, not only that, I still come back to age and sex. Some you give me an ECG, and what do you make with that? Make about that? And the first question I'll always say is, what's the age and sex of the patient? And actually, one of the tricks for separating male from female ECGs is just to look at the ST junction in V3, and you'll find it's relatively high in males compared to females. That's a small minor point. But there are all these wonderful AI algorithms these days that can tell you the sex of a patient from the ECG. But actually, if you've looked at enough of them, you should be able to have a good handle on that. Yeah, I take the point, and yes, the ECG should be interpreted at the bedside with the patient. It's not, that's clear, and that's what happens in A&E and so on, but it's not always possible for those that report ECGs to be at the bedside, and particularly, if you're in some general practice and you're not experienced, or family practitioners not that experienced in ECG interpretation, with all respect, and that is getting passed on to somebody down the line who's clearly not with the patient. So it's not always feasible to do that. But we keep saying that the automated interpretation is a second opinion. It's a valuable, very valuable second opinion, because, and the reason for that is kind of basic, that you would never say to a colleague, consultant cardiologist, or whatever, this is what you should, this is definitely the answer, because that individual may have their own take on an ECG. No cardiologist likes to be told he's wrong interpreting an ECG. Well, there are many publications to show observer variation, and we did that with 8 cardiologists in the CSE study that I referred to earlier. Not necessarily 8 different opinions, but different opinions on ECGs. So you can always say, well, look, here's a second opinion. You may have missed something. And that, I think, is the best way to look at the automated report. I can't really take it much further than that. Each individual cardiologist will think he's given the correct interpretation. But you can only say, well, have a look at this, and maybe that helps, maybe it doesn't help, maybe it reinforces what you think, and that's fine.
No, indeed,
We never
indeed.
sell it as this is always a perfect. You can never sell an automated interpretation as being perfect. And convert, you can't. I could take a very specific situation these days with how accurate is ST depression in occlusive myocardial infarction. That's a separate discussion altogether here. I think to some extent it may be non-specific, but I better be very careful what I say, because I can only look at the literature and listen to colleagues, etc.
Well, that brings me actually quite nicely on, Peter, to iterative improvements in the algorithm, because only a couple of years ago, there was some substantial iterations and improvements to the algorithm. Could you maybe speak to those that you brought in over the last few years?
Well, the big improvement I have to come back to is age and sex, more widespread use of age and sex. And that even applies to left ventricular hypertrophy, something as basic as that. Ask any cardiologist what his or her criteria are for LVH. And I think the vast majority will initially talk about Sokolov and Lyon. Now, what's that criterion? It's SV1 plus RV5 is greater than 3.5 millivolts. That's nothing about males and females. Then look at the distribution of that measure with age and sex. We published that years and years ago. Young men have a far higher measure of SV1 plus RV5 than young women. And then it decreases with increasing age. So you must have age and sex-based criteria for LVH. And it was interesting to note, if you look at the criteria for athletes, that now the most recent set of criteria for interpreting the athlete's ECG does not really come up with a firm criterion for LVH. It's very reluctant to begin to report LVH in athletes, which is good. Somebody's cottoned on at last to, you can't just call young guys with high voltage, call them as having LVH, not at all. So that's another good example of how people are beginning, long last, taking age and sex into account. I remember, I'm sure, one famous American textbook in its, I better be careful, a very high edition of this book, not a single reference to males and females being different in that textbook. And the author had said, how do you think I can improve this? I said, well.
Absolutely, absolutely. So a little bit off script and indeed just from top of mind, Peter, but looking at leads which are placed in the sort of to look at the posterior aspect of the heart, it seems to be more of it's really come into vogue and or into practice in contemporary practice. Could you maybe speak to the evolution of that? Was this something that became apparent 30, 40 years ago? Was this something that sort of really became apparent to yourself only sort of 5, 10, 15 years ago?
Well, I have to be honest and say that there's very little use of additional leads in my experience. And you talk to the interventional cardiologist, that will say, what's the point? I'm going to do cardiac catheterization here. So I'm not too worried. Patients get a lot of chest pain, blah, 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 raised troponins. I'm just going to do cardiac catheterization, irrespective of V7 to V9 or right-sided chest leads, etc. That's my experience, all I can say. Yeah, if you go around the back to get looking for ST elevation in V7, V8, and V9, that's tantamount to a little bit of ST depression in V1, V2, V2 perhaps, V3. And then we're into this concept of ST depression being consistent with myocardial infarction. We've always had, we go back to publications, Scale and Wagner and I were on a paper, 2009, the series of papers where widespread ST elevation was consistent with multivessel disease, etc., even in an acute situation. So there has always been this thought that you've had to search for ST elevation before you can say myocardial infarction. And I don't think that's right. And our software has always had a headline of acute MI stroke ischemia in the context of fairly marked ST depression, which is consistent, definitely consistent with an acute MI.
And I think one of the things in the pre-hospital environment it is quite challenging is that you can't necessarily test for raised troponins, but you can get figuratively you can get a number of iterated ECGs in that consultation. It's sometimes quite hard to look at previous ECGs if indeed the patient notes aren't there, but to your point around, patient assessment and just patient and history, a really good, accurate history with systematic assessment and indeed ECG. It's almost as good as it gets at the moment in the pre-hospital environments, but that history is so important around, the archetypal pain, where the pain is, where it's migrated to, is it frequently reoccurring, like you say, the age, the sex, the ethnicity, and some of these markers together with the ECGs. But it's still very challenging without that third almost triangulation where we don't have access to raised troponins. But there is that accurate history taking. There is that phased approach where you can take repeated ECGs over time, and then fundamentally looking at the patient, the pallor, is the patient sweaty, and looking at comorbidities as well, and that seems to be where it is at the moment. Do you see any advancement to that? Do you see any sort of advancement in the pre-hospital environment where we can be even more accurate in our diagnosis?
That's a very difficult question to answer, and I would say I don't see any immediate advancement. Probably those who are keen on AI type of techniques will tell you, well, if you get a big enough database, that's going to give you the answer. But a big enough database could apply to non-AI methods as well. I think that would be the secret, really. And one of the points that we could look to in the future is a well-defined database of ECGs on which improved interpretation could be based. I know that at the minute, some of the developments, such as from the Mayo Clinic, they've got 2 million ECGs plus. There are even bigger databases now available, but these are not the gold standard. Is really one individual who's looked at some of the ECGs, and another individual's looked at a different set of ECGs over the years. So there's not an agreed gold standard for these very large databases. I mean, I think, was it the Massachusetts General, I may be wrong, have released 10 million ECGs to the PhysioNet database, but I don't think there'll be 10 million classifications with them. So you've got to, the only way I can see it here is get really well-defined databases. It would take a long time to do it. But you never know, with MRI, you name it, all the different tests that are now available that weren't available in the early days, put it all together. Well, maybe they don't have to have a million to get this, a million ECGs to get this correct, but just a well-defined group of a good-sized number of ECGs with some kind of international approval, that would be a good database to use. Then we begin to see some advances. And I can't think of a well-defined database that I could go to get 1,000 ECGs, 2,000 ECGs that are absolutely rock solid. This is clinically classified and proved and all the rest of it by various tests.
And so just as we're coming to land, Peter, on the interview, just a couple more questions really. And one will be about researchers and sort of how and where you could give advice to researchers in the field for different areas of exploration. But just before I ask that question, this is more out of my curiosity, really, just about what you're working on at the moment and what sort of the emergent needs and or demands on your time are at the moment.
Demands on my time. Where do I start? From cutting the grass to to sometimes helping out with 5 grandchildren. Well, maybe some of them were a bit grown up.
Yeah,
to be
indeed,
honest.
indeed.
Demands. Well, I'm at an age where I have to be thinking who's going to be supporting if I'm not around. So there's a bit of a demand on time there and on planning ahead. I think we would like to delve a little bit into AI-based methods, but not go overboard on AI. Our toe is in the water at the minute. But certainly, yeah, a little bit more time will have to be spent having a look at that. That's a separate issue I could talk about for a few minutes. But they're just keeping up to demands on time are everything from management through to research, PhD exams, grant applications to be dealt with, just papers to be refereed. Some of those listening will know exactly what I'm talking about. It's not X hours a week that are all spent on ECG interpretation.
Yeah,
No,
indeed.
it's not that way at all, I'm afraid.
No, indeed.
Lots of things to be considered.
Yeah, I'll tell you what we will do, Peter, just before I do ask that final question, is just around, we will put in the show notes some of the papers you have referenced in the interview, actually, because they're fantastic reading. And like you said, they span the whole corpus of time from your career. So we will put those in the show notes so listeners can go back and read those papers. Those fundamental, really, those seminal papers. I guess my last question really is, Peter, around areas of research or expansion. If researchers wanted to dig into the field of medical informatics and ECG interpretation, what are some of the emergent themes that you're seeing, or indeed refereeing within a PhD thesis or PhD candidates? What seems to be coming up on your desk a lot?
Well, there's no doubt that artificial intelligence is flavor of the month. And what is of great interest is that the ECG is now being used to comment on, say, left ventricular ejection fraction, which in the past would never have been regarded as something that you could determine from the ECG. But I would like to caution people not to go overboard on this type of thing, and to look very carefully at the publications and look at the positive predictive value. It's very important to look at, to my mind, to look at the positive predictive value of these types of diagnoses. And I would say you certainly cannot use, from what I have read and what my view is, you cannot use that algorithm in the general population. If you want to target patients where you think there's a reasonable chance of LV dysfunction, then by all means, run that ECG test and see if there's a sort of simple guide from the ECG that might say, well, we don't need an echo in this patient. Clearly, there's if you trusted that algorithm, that's fine. But the positive predictive values are low, even from those that have got FDA approval. When you look at the papers very, very closely. So, but by all means, dip your toes into AI and see if you're going to come up with something which will be an advance and will be able to be used to best advantage. I mean, we've very, very recently had conversations about the ECG in pediatrics. And it's interesting to read the paper from, say, Boston Children's Hospital, where they have a similar concept of looking at the ECG to report LV dysfunction or LV dilation, along with LVIH in different groups of children, perhaps with cardiomyopathies. Now, again, I would suggest, and I don't know, but I would suggest if that was applied widely, there would be some, difficulties with false positive cases. But if it's applied to the group who are suspected from other reasons of having cardiomyopathy, etc., then that could be, it's another example of the ECG in being used in areas for diagnoses that we would never have thought of in the past. But there's still room where there is no internationally acclaimed database for arrhythmias that, right, here's a database of 2,000 arrhythmias. 3 or 4 cardiologists have agreed this is definitely the report, and you could submit your program for assessment on that internationally accepted database. Everybody does it individually at the minute and presents their own statistics. And we can say that for almost every area of ECG interpretation. There is no universally accepted database for virtually every category of ECG abnormality that there is. So if you're young and enthusiastic and you think you've got 20 years to build up a nice big database, there's room for you to get going.
Indeed, Peter, indeed. Listen, that's fantastic. And to your point around AI, and just where it's coming to, just from a diagnostic perspective, it's really interesting. There's a lot of remote interpretation from rural GP settings, Australia, New Zealand, US, where there is interpretation of remote radiological interpretation. So there's of CTs, of MRIs, and it's starting to become it's really proliferating into lots of areas of healthcare actually around, and it's just super interesting, like you said, as to where it's going.
Yeah, well, I'm supposed to have a tour on Friday of the quantum technology unit at the University of Glasgow, and they're into healthcare with quantum technology. So
gosh,
I'm excited to see what I'm going to see on Friday this week. So.
Yeah, indeed. Peter, listen, we're just at the top of the hour. It just leaves me to say thank you so much for your time. It's hugely beneficial just to get your perspectives and insights. And we'll make reference to the papers you mentioned within the show notes. So, but thank you again.
Pleasure, and thank you for the invitation.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.